I will talk about inhibitors, which is, as you know, the most important complication of the treatment of patients with hemophilia. Around 30% of people with severe hemophilia A will develop inhibitors against their therapeutic factor VIII product. That's why we call them alloantibodies. And this adverse event may result in more life-threatening bleeding, disability, impaired quality of life, and costly care. Patients with inhibitors in general do not bleed more frequently than those without inhibitor. The issue is that the treatment of their bleeding episode may be less successful, and this is because bypassing agents are not as reliably effective as is the case of the replacement therapy. The majority of the inhibitors will develop during the first 50 exposure days. We call an exposure day a calendar day when the patient receives at least one dose of factor VIII or factor IX. And approximately 15% of inhibitors arise in patients with non-severe hemophilia. But what is an inhibitor? This is a neutralizing antibody, IgG, that inhibits the procoagulant activity of the infused factor VIII or factor IX. How is it detected? We use, in general, a specific assay that we call the Bethesda assay, specifically one modified version that we call the Nijmegen assay. When can we detect the presence of an inhibitor? Well, during a routine screening test, as I said, during the first 50 exposure days, we usually ask more frequently for the Bethesda assay in order to detect the presence of the inhibitor as soon as possible. Or we can suspect the presence of an inhibitor if we are facing a bleeding that does not respond as expected to usual factor concentrate dose. Who will develop an inhibitor? We know what we call risk factors for factor VIII inhibitor development, and we classified them into genetic factors and environmental factors. Within genetic factors, we have family history of inhibitors, factor VIII mutation, which means that we know, for example, that a patient with a multi-domain or a large deletion has a more risky situation to development an inhibitor than a patient with a missense mutation, for example. HLA genotype and some polymorphism connected with some immune regulators genotype. Within the environmental factors, we have treatment intensity, age at initial treatment. It means that the younger the child receives an intensive treatment, for example, the higher is the risk to develop an inhibitor. The type of clotting factor replacement. Now we know that replacement therapy beginning with recombinant products is a riskier situation to develop an inhibitor than the use of plasma derived IMPAPs. And situations with coexistent inflammation like a surgery, a major bleeding, etc. What about hemophilia Bian inhibitors? Well, this is a rare situation. The incidence of inhibitors to factor IX is less than 5%. The factor IX genotype is a major risk factor for inhibitor development, where large deletions are clearly more related with the development of an inhibitor. And this is a very characteristic situation for people with hemophilia B, which is in at least 50% of cases, factor IX inhibitor development is associated with allergic or anaphylactic reactions. How we classify inhibitors? Well, we call them transient if they spontaneously disappeared within the following 6 months after the diagnosis, or we call them permanent. When we do the Bethesda assay, we classify them as a high titer when they are more than 5 Bethesda units per ml, or a low titer if they are less than 5 Bethesda units per ml. If we consider the anamnestic response, this is what happened with the titer of the inhibitor after the re-exposure of the patient to the factor 9 or factor 8. We call them high responding inhibitor when titer rises more than 5 Bethesda units per ml, or if the inhibitor is always less than 5 Bethesda units, we call them low responding inhibitors. How we manage inhibitors? We have to consider the immune tolerance induction treatment. We have to consider the treatment of bleedings and also prophylaxis in patients with inhibitor. In connection with immune tolerance induction, this is the optimal treatment strategy in hemophilia A patients with inhibitor in an attempt to eradicate it. ITI therapy is indicated for all patients with a confirmed inhibitor that interferes with prophylaxis or treatment of bleed at standard doses of factor VIII. There are different protocols using low or high doses of factor VIII. The important issue is that ITI success rates are 100% for low responding inhibitors and between 60 and 90% for high responding inhibitors. The goals of this treatment are to restore regular administration of factor VIII concentrates for bleeds, surgery, and prophylaxis, to prevent hemophilic arthropathy and enhance patients' quality of life. Again, what about inhibitors in hemophilia B patients? Well, the issue in this group of patients is that there is a relatively poor overall success rate for ITI, and there is a high risk of complications in this group of patients with allergic reactions and also with nephrotic syndrome. I'm not going to describe in detail the doses of bypassing agents that we usually use for treatment of bleeding in patients with inhibitors, but I would like to show this algorithm, which is used when we are facing a patient with an inhibitor. If the inhibitor is a low responding inhibitor, we treat the majority of the bleedings with high doses of factor VIII or factor IX. If the inhibitor is a high responding one, and we are facing a minor bleeding, we should use a bypassing agent. We have 2 bypassing agents available, the activated recombinant factor VII and the activated prothrombin complex concentrate. But if we have a patient with a high responding inhibitor and he is suffering from a major bleeding, we should know the current titer of the inhibitor. If it is less than 5 Bethesda units per ml, we can use high dose of factor VIII or factor IX, but we should monitor daily the target plasma levels. But if in that moment the titer of the inhibitor is more than 5 Bethesda units per ml, the only available possibility is to use a bypassing agent. It is important to consider that both bypassing agents appear equally successful. Either agent may be tried first, but we have to consider that 10 to 20% of bleeds are not satisfactorily resolved with one of these bypassing agents. Some patients respond better to one or the other bypassing agent, and we don't know why. The mechanism of action of bypassing agents is completely independent of the inhibitor titer. We can use antifibrinolytic agents, tranexamic acid or epsilon aminocaproic acid, especially for management of mucocutaneous bleeding. And in the case of non-severe hemophilia patients with low-titer inhibitors, we can consider the use of desmopressin if we are facing a minor bleeding. In connection with prophylaxis in patients with inhibitors, it is not clear when to start prophylaxis in this group of patients, but we should consider prophylaxis for inhibitor patients who experience frequent or life-threatening bleeds. There are different regimens. The important issue is that the majority of them are reported to be effective, to be used as prophylaxis to reduce the presence of frequent bleedings in this group of patients. Finally, I will talk about a new treatment for patients with inhibitor, which is the emicizumab. This is available in some countries. It is a recombinant humanized biospecific monoclonal antibody that bridges factor 9, activated factor 9, and factor 10 to finally activate factor 10. It is used once a week by a subcutaneous dose, and it is indicated for prophylaxis in patients with hemophilia A only with inhibitors to prevent or reduce the frequency of bleeding episodes. Finally, I would like to remark that inhibitor development is a challenging complication of the treatment of hemophilia, that the best treatment option is the first attempt to eradicate the inhibitor through the ITI treatment, that we should consider that any minor bleeding can become a severe one, and all surgeries should be considered as high-risk procedures. They should preferably be done in hemophilia treatment centers and performed by surgeons with experience in hemophilia. Thank you for your attention.